I will give the floor now to Mabel, Johana, Ortiz from ICARS, who will present some of the work done by ICARS in different settings. So, Mabel, the floor is yours.
Thank you, everyone, and thank you for EU-JAMRAI for having this invitation and for having me here. So I'm Mabel De Leo. I am a science officer at ICARS. So for the ones that don't know, I'm going to talk a bit more about ICARS in this presentation, but we are an organization that works towards developing interventions that are based in local context to tackle antimicrobial resistance. So I will share my screen so we can talk a little bit more about it. Can you share my screen? Is it in presentation? Sorry, see
Yeah,
my screen. Is it in presentation mode? Okay,
yeah, this
perfect.
is perfect.
Okay, thank you. So this is the agenda for today. I wanted to keep it short, but also to talk a bit more about the stewardship and IPC measures that we have and projects that we have in ICARS. So first of all, I will talk a bit about antimicrobial resistance and how it is in the global context. We're going to talk about One Health, linking global and local stewardship across sectors. What is ICARS? What is intervention and implementation research? So it is the core of the research that we do in ICARS. Some examples of the projects that we have in low middle income countries, because in ICARS we work with LMICs across the world, and some lessons for sustainability. So try to come with some examples to bridge research and policy, which are very important and is the aim of the work that we do in ICARS. And at the end, some closing remarks. And in case you have questions, I'm very happy to respond to them. So a bit to talk about what is happening in the global context in AMR. So according to the global burden of antimicrobial resistance, so from an evaluation that was done in 1990 to 2021. So there were 4.71 million deaths associated with bacterial AMR. So this was in 2021, and 1.14 million deaths attributable to bacterial AMR. So we have to remember that associated is not the same as attributable, right? So, and it's important to note that like attributable, it means a direct correlation. So 1 million deaths were attributable or directed related to bacterial antimicrobial resistance, which is quite scary because that means that the antibiotics are not working anymore and they would increase, in the further years to come. And from these numbers, 50% were related to AMR deaths in children like younger than 5 years. And there was an increase of AMR deaths among adults living longer than 70 years, so 80%. I forgot to say, so in my background, I'm a medical doctor and I have worked in infectious diseases and also AMR before. And for me, sometimes it was quite scary, to see the antibiograms coming or the reports coming from the microbiology department in the ICUs in my hospital with R. So I know like some of you, because I know I'm like presenting to some healthcare workers here. So I'm sure you have faced the same, and it's coming more common nowadays. So for the future projections and impact of AMR, 39.1 million deaths are attributable to AMR. So this is going to be projected from 2025 to 2050. So this is just a projection, but it seems that, as the pace that we are going, and more specifically in low middle income countries, this will likely be the picture that we have. 1.91 million annual deaths are attributable to AMR projected by 2050, and associated with AMR is 8.22 million. So for people aged 70 years and older, 65% of AMR deaths will occur. So yeah, it's more related to people living longer and, having more diseases or chronic diseases. There's potential to avert 92 million deaths through better care, which is quite promising. So by implementing new measures in improving the healthcare, this can be averted. And also there is a potential to prevent 11.1 million AMR deaths with new gram-negative drugs, which this is a lot of numbers and statistics, but I think it's important to see because, a lot of these can be averted. So if we implement measures, and I also always say that you don't have to reinvent the wheel, right? Okay, yes, we have to come with new diagnostics, with new antibiotics, but there's a lot of measures that you can do, or we can do as healthcare workers to prevent AMR. Simply, for example, sharing how, like, the steps to wash your hands, right? How to wash your hands properly, having an alcohol-based rub in your hand or in your bag, showing everyone how to use it. So there's like these little things we can do daily to prevent these numbers. So the highest burden, and we know, is in low middle income countries. Sub-Saharan Africa has the highest death rate attributable to drug-resistant infections. And Asia, particularly South and Southeast Asia, bears one of the largest burdens in AMR globally. And it's not only the impact that we have, that AMR has in the healthcare, but also the impact that it has on poverty. It's an economic impact, and also the implications in a societal level. So the countries that are already poor and that will continue to face these AMR infections are going to become poorer, because it is just a cycle of this impact of AMR increasing extreme poverty. And of the 20.3 million people living in poverty in 2050, the vast majority, so 26, so almost all, it's only 2 million that won't, would live in low middle income countries. So there's also an important thing to note. The global antibiotic consumption has increased compared to previous years. So by 65%, it increased to 2000 to 2015. And it's important to know that, of course, now after COVID and in a world living in a post-pandemic world, this is even worse. So there's some papers that show that the antibiotic consumption has increased doubled, like since the COVID pandemic. And the one antibiotic consumption increased 90% worldwide and 165% in LMICs, according to the WHO aware classification. So yeah, 165% in LMICs. It's quite alarming how the antibiotics have increased. And this is in humans, but also we have to think about the animal sector. And as I said, I'm a medical doctor, so I wasn't aware a lot of what happened in the animal sector. So now I work in a One Health lens and perspective, and I have learned a lot of how these antimicrobials are also, given in the animal health sector. So more than 70% of antibiotics are used in food-producing animals. Global consumption of animals is projected to increase by 50%, so people are eating more animals. And 25% of all countries still report use antimicrobials for growth promotion. So it's not only to treat or the prophylaxis or the treatment of these animals, but also for growth promotion, like colistin. So we need global action, and we need like an international effort to address AMR. So it is usually, you know, in the scale. I think there's a lot of programs that have a lot of funding. For example, vaccination programs, pandemic preparedness programs. So there are a lot of investments in this, but AMRs is still neglected. So, and even not only neglected, but there's a lot of lack of coordination. So 170 countries had developed multi-sectoral national action plans. So these national action plans, for the ones to know, each country needs to come with a national action plan to implement measures against AMR. So some of them are in early development, and some others are in implementation. But only 67% of the countries worldwide are currently implementing their national action plans. And only 28% of the countries have costed and budgeted their NABs and are monitoring implementation, which is very important, because without money, you cannot do change. And this is, like, I think, an international law everywhere. So you need to budget, and you need to say, okay, these are the measures that I have. This is how they cost, and this is how it will be, the cost benefit of having these measures implemented. So a One Health approach and a global action is crucial, and that we all know. We cannot work in silos. We have to work together, not only with a human health perspective, but a plant and also animal health perspective. and have these AMR interventions integrated. So having them in the universal health coverage, also in pandemic preparedness, in food security. So AMR, so every program in country should have the AMR perspective and the AMR lens as well. So this slide is taken from the WHO Global Status of AMR National Action Plans. And as you can see here, so it's that not national action plan has been done. So 16% of the countries haven't done a national action plan. But then, 16 countries. And then we have that 67% they have it and are currently implementing them, but only 18 have actually, costed and evaluated how this implementation is doing. So most of the national action plans in country against AMR are here in this yellow bar. So they're developed but not yet implemented or in that roadmap. So there is an implementation gap. So 28, as I mentioned, have their NAPs, but that have been costed or budgeted. And then it's important that we think that it's not only, the national action plans in country, but also which measures can be applied, like with a One Health perspective. And stewardship is very important because the stewardship like secures that the antibiotics are used and given adequately and also preserved for future generations. So I want to show some examples of how we can link global and local stewardship across sectors. And it here is also, really relevant to mention that we have different AMR drivers. So AMR is not something that comes well, it comes naturally, but also some things can make it worse. So we have AMR specific drivers and AMR sensitive drivers. For the AMR specific drivers are the ones related to the use of antimicrobials. In human health, for example, 30 to 50% of all antibiotic prescriptions are inappropriately prescribed. And as I mentioned, it is a problem everywhere. We know that there's a lot of countries that they don't have any antibiotic regulations or any antibiotic prescriptions. So you can go to a pharmacy, have antibiotics, and even in some countries in their black markets, they just send antibiotics or they're counterfeit. They don't have any regulations. So it's quite important to note these numbers. And in animal health, antimicrobial use is extensively in livestock for prophylaxis, metaphylaxis, and therapeutic processes. So for example, in the pig sector, antibiotics are given prophylactically, even if the pigs don't need it to prevent diarrhea after the weaning period, or metaphylaxis. So when a pig is sick, to prevent the spread of this bacteria, they put medicine in some of the antibiotics in the feed. And also, with the therapeutic in case pigs are sick. And then in plant health, medically important antimicrobials, oh, sorry for the typo there, to plants are for prophylaxis. So at least 10% of rice crops in some countries are already receiving medically important antimicrobials. So for the people that eat rice, at least 10% of these rice crops have antimicrobials already. So yeah, we have antimicrobials everywhere. And then we have AMR sensitive interventions and things that cover this area. So we have the WASH initiatives, and this is related to some countries. And when I was like doing this presentation and reading these numbers, I was like only 25% have waste treatment coverage, and this is specifically for LMICs as well. And then there's then some countries only have sorry, in the global scale only 60% of them have wastewater that is related to wastewater communities. So then if you can see, I think this is very common in a lot of countries, just having the trash and just having the wastewater contamination across the populations. But also we have other interventions like the infection prevention and control, biosecurity measures, and vaccination, which this infection prevention and control is in humans and biosecurity is in animals, but this is across sectors, right? And vaccination as well. You can perform vaccination in the three sectors, in animal, human, and plant health. So I think a lot are aware of this image, working and the One Health. So this diagram of the humans, so the antimicrobial use, and then it comes to humans, and then the animals, and then you eat the food, and then there's manure, and it comes to sewage and environment, and then this is this cycle. But I think it's not only like we cannot think it only as individuals, because sometimes it's like, okay, this is what I can do as a person to prevent AMR, so don't eat that meat, or try to wash my hands more frequent, but we had to think it as a system, right? It's a bigger picture. So here, that's why I wanted to show that in the image in the right side, you have these big fabrics that have like wastewater treatments. You have these big healthcare facilities, huge hospitals, like throwing antibiotic resistant genes, to the wastewater. And then it comes to the urban settings and also to the water environment. So it's not only thinking about an individual perspective, but in a macro perspective of how these pathogenic bacteria are in the wastewater and in filtering everywhere. And for this, I wanted to show that it's not only a matter of having these AMR sensitive or AMR specific interventions, it's also how these are implemented. So according to the situation analysis of IPC implementation around the world, and this is from the TRACS system, so 162 countries don't have an IPC operational program. So at least 11% don't have any infection prevention and control measures. And from this, only 19%, and this is mostly high-income countries, had a system to monitor the effectiveness and compliance of these programs. So if we want to do like an average and have some numbers in the middle, 54% have operational plans that have not been implemented. So half of the countries have an IPC program, but they have not been yet implemented. So it's just written in a desk somewhere in the hospital. And I think that's very common to see around the world. And if we see it from a healthcare perspective and a health care facility level, there's significant differences. So in this image, the blue, like not the light blue, but the strong blue lines show that there is like low income countries. So according to these IPC scores by core component and World Bank income level, so low income countries are the ones that are having lower scores compared to high income countries. And a lot of low income countries scored basic. So they have basic implementation level in IPC guidelines, training and education, monitoring, audit and feedback, and healthcare associated infection surveillance. And there's a lot of challenges for implementing these minimum requirements for IPC programs. So I think, and according to this infection prevention and control assessment framework, they are covering 7 core components, but I think some of them, and I was reading this, I don't want to cover all of them because it's a lot of text, but some of them are very basic, like the lack of IPC experts and mentors. I think it's not hard to have a person in the hospital that is just, specifically trained to do IPC. So yeah, and we can think about it. Yeah, someone can come and be an AMR champion, right, or be an AMR IPC champion, but it's in reality it's harder than we thought. So there's a lack of standardized IPC curricula, lack of career pathways and development for IPC professionals. There's a lack of expertise for among auditors. So there's a lot, there's not training around how to do HAI surveillance. We need more high financial investment. For multimodal strategies, behaviors are very important. An organization that do not conform to international standards. So I think behaviors is an important thing to mention. It's very hard to change behavior. Um, And of course, the workload, staffing, and bed occupancy. And I think this is very common in a lot of hospitals across the world and more in LMICs. I don't know if you're aware of this. I come from Latin America, so it's very common to see people just lying in the floor waiting for a bed. Sometimes outside the hospital. So there's any infection prevention and control measures. So it's also staff that are quite tired, and we also saw that in COVID. People that were very, very tired and working long hours, because we don't have enough human capacity for that. So I think these challenges are very common. And then this is in human health. If I didn't mention that, but then I wanted just to show a little bit more that it's not only to focus in prevention. So because we think, okay, AMR, we need to prevent AMR by, having IPC measures in place, having WASH measures in place, having vaccination. But it's not only that. It is such, an intricate system that we need to tackle. So it's not prevention, but also we have to innovate with novel therapeutics, vaccines, associated diagnostics, developed with stewardship principles, incentives. Yeah. So this is basically to improve what is already there. Access, equitable access is very important, because if you focus in having access in certain parts of the world and then the rest is not covered, we still face this transmission of antimicrobial resistance genes around the world by traveling, for example. So access, regulation, and technology transfer is very important. And of course, care. So the informed use of antimicrobials through diagnostics and diagnostic stewardship. And I'm focusing here in human health and animal health because these are the examples that I'm going to present to you later in the presentation. We are also in ICARS working in climate change and in environment health projects, but I'm not working directly to them, so I will defer that to my colleagues working in those. So that's why I wanted to focus on this. And in animal health is the same. So it's not only preventing by vaccinating, for example, the sows in pig health, having proper biosecurity measures in farms or good husbandry practices, but it's also what diagnostics you have in place, what kind of vaccines you have in place, which is the access that you have. So affordable therapeutics, effective vaccines, management and distribution. And I think it's also very important regulation, something that is missing here, because you can have all of this in place, but if you don't have a system to regulate who's prescribing what in farms, everything goes away. So, and the care, of course, informing the veterinarians and informing the farmers in place how to use and the antimicrobials. So I think it's quite important to see this with a big lens, an ample lens of how IPC and AMS should be together in the antimicrobial life cycle. So this publication is it's very new. Not only, it's not only covering from research and development, because then we think, oh yeah, you know, the people that are in labs, they should focus more on, and maybe there's people here that work directly in the laboratory. So it's not only that, like, oh yeah, we need new drugs, we need new antibiotics. So it's not only that, it's to work together in the production system. Then how do you registrate those antibiotics and evaluate them? Then you need to ensure, sorry, the procurement and supply of these antibiotics, and also make sure that they have appropriate and prudent use, and of course the disposal. So it's such a intricate chain of things that should come together, so these stewardship efforts come into place. And then for the ones I'm sure a lot of people are waiting for, okay, so that's very interesting, but what do you do in ICARS? So as I mentioned and in the first slide when I was introducing my presentation, we work with the intervention and implementation research framework. So it's a lot of applied research. It's having evidence that works in some settings and implementing them in the real life and in the local context. So I will talk a little bit more about this. So ICARS, we partner with low and middle income countries to reduce AMR using a One Health approach. It was funded in 2018 by the government of Denmark upon dialogue with the World Bank. Now we have other funders, not only the government of Denmark is supporting us. We're based in Copenhagen, by the way. And right now we have 55 projects in 25 countries and territories. So we are across the world. We're an international team working across multiple projects and also within the One Health sector. So we have veterinarians, we have climate change experts, and we have, like me, doctors working in human health. And this is setting, how this is set, or how does ICARS work. So we provide funding and technical support to governments and research institutions in LMICs for AMR mitigation interventions. And it's not only providing the funding, but also we co-create and co-develop solutions that are context specific to support the implementation of their AMR national action plans. So this is also driven by national priorities. So we don't come with an agenda. So we let the countries decide what is most important to them and what is a priority to them to tackle. By this, we expect to bridge evidence, policy, and practice. So we work in solutions that are evidence-based, so that have a scientific context. Okay, this has been the evidence or the peer review process shows that this works in some context. So then we try to adapt them because a lot of things published don't work for all of the settings. So we try to adapt them according to what we have in the setting, and I think that's the most difficult part of our work. Try to work with what you have, basically. We also try to make that these solutions are cost effective. So for all of the projects, we do economic evaluation to try to understand if it's better, at least to prevent disease and then try to reduce the AMR burden by this. So we try to do the cost benefit evaluation. We try to these solutions to be sustainable. So what happens after we leave the country and we leave the support for these 3 years projects? As I mentioned, working with the One Health lens, and we try to bridge policy and practice. So in this map, I can show you how, and you will see, so we have, in 2024, we had 55 projects, but now we are to 58 in 2025. And we have more than 170 partners in several countries and territories. And here you will find that we have projects. In some countries, we have across the One Health sector. So for example, in Colombia, we have animal health and human health. In others, we only have animal health or we only have human health, like for example, Pakistan. So if you want to learn more, I'm attaching, and I will send my presentation later. If you want to learn more, you can visit the website. But yeah, we are around the world, as you can see. So the core principles of ICARS, like the most important, that it should be country ownership. So this should be executed by local researchers, priorities based on local needs and challenges. So we don't tell them what they should be doing. It's the opposite. They come to us with a priority, and we try to support to the solutions based on that priority. So we have a collaborative multi-sector analytic approach involving human and animal sciences, environmental sciences, social sciences, and economics. So it's not a siloed intervention. We try to work across multiple partners. Yeah, so we deliver evidence in partnership with key stakeholders in countries. So most of the countries we work with the ministries. So in this case, if it is a human health project, we work with the Ministry of Health. If it's an environmental health project, with the Ministry of Environment, an animal health project with the Ministry of Agriculture, for example, or animal health. So we are solution focused, producing scalable evidence solutions for policy programs and practices. And as I mentioned, the most important, having cost-effective solutions. Um, so this is our approach is country determined. We do the intervention and implementation research framework. We co-develop and develop also capacity in the country. So we try to support also that the persons in country can do a PhD or a master's students or a master's program, so that they become champions and they can train others in the country to support these needs. Um, so, but truly sustainable solutions need political will. So this is very important. So we cannot go to a country in which the researchers are very interested to work with us, but there's any political engagement, because what we want to do is that these solutions are sustainable after we end these projects. We need ownership from the country throughout the whole stakeholder chain. So from the beginning to the end of the project, they need to be context specific, evidence based, and also the country capacity needs to be in place. So we work with a lot of strong researchers across LMIC. So it's great to see all the capacity that is in the country. I've always said that there's a lot of capacity, but it's like there are poor incentives from the governments in the country. So it's hard sometimes for them to have these opportunities. So it's great that this is, something that we can provide to them. We want to understand how is the behavior of people toward the use of antibiotics and the cost effectiveness of them. And intervention and implementation research should be demand driven, should be context specific, and should be real world. What is happening? Should be multidisciplinary as well. So we're not working only in clinical research. So for me, it was when I started working in IIR, it was very difficult for me to have this, mindset of including other sciences like social sciences, health economics. So it's working with a broad perspective, and it should be multi-stakeholder. So intervention and implementation research studies both the effectiveness of health interventions and the strategies to successfully integrate them into real world practice settings. And I really like this diagram because here you can see that you have several settings. So it's the outer setting, so the political, economic, and social contexts. You have the inner setting, so what is happening with the individual and the use of antibiotics in this case. So the networks that person has, the access this person has to the clinics maybe, or what is around this person. And then also the stakeholders, so the main people that have a direct role in the implementation process. So which actors are the ones that you want to include in your research? So with this, we do this stakeholder mapping at the beginning of the projects to identify which organizations, so which partners or people or individuals are going to be the most relevant to engage from the beginning in our processes. And by this, facilitate the adoption of interventions across the intervention and implementation cycle. So it's all through the phases of the research continuum. Measure in our projects. So the intervention effectiveness. So it's not that we only do the intervention, but also we evaluate if these interventions were effective. So did we reduce antimicrobial use? Did we enhance animal productivity? Are there any specific clinical outcomes like less length of stay, less mortality, less healthcare associated infections, for example? We try to evaluate the social and behavioral change. This like is are people thinking differently about antibiotics now? Do they continue doing the same behaviors or activities that they were doing previous the project was implemented? And of course, the economic impact. Is it better to save money by preventing, or is it just costs the same, to avoid infections? And as I mentioned, we have students in country also. So now we have 46 students in ICARS projects. So these are engage from the beginning till the end of the projects, and we also cover their tuition fees so they can, work on the projects and then also have capacity strengthening. So it's very important to have local expertise in countries so they can become AMR champions in the country. And then I will give you an examples of 3 projects. And you may think, it's not a lot because we have 58 projects now. So this is some projects I'm working in. So this one is in the pig sector. And I don't know if there are any veterinarians in the room. I'm not a veterinarian, so if I don't have any technical expertise in this, but I can talk a little bit more about what we do. This is in Colombia. So the project is reducing antimicrobial use to improve provision of colostrum and use of vaccines in weaning pigs. So for the ones that don't know, weaning pigs frequently develop diarrhea and is correlated with lower growth and higher morbidity and mortality. So in many cases, the etiological agent is not diagnosed because, they're just giving antibiotics, and pigs are treated prophylactically or therapeutically with antimicrobials. So the project, it was basically to assess the effect of an improved colostrum and vaccine protocol intervention. So the sows were vaccinated, and they have a specific vaccination protocol uh, before the intervention was done. So the sows were vaccinated, then the weaning pigs had a colostrum protocol in which through strengthening biosecurity measures in the farms, they were giving the colostrum from the sows, and they were rotating the piglets, because something I didn't know until I was in these farms is that sometimes the sows just push them away and the piglets die. So by having a veterinarian in place trying to rotate these piglets, they make sure that they ingested the colostrum, and by this, their immune system or their defenses were higher, and this prevented diarrhea. So here we were working with the Ministry of Agriculture and Rural Development with Port Colombia, which is the implementing partner in Colombia, is the biggest association that works within the pig sector in Colombia. We work with the Universidad Nacional del Centro de la Provincia de Buenos Aires in Argentina and the Colombian Agricultural Institute from ICA. So some of the outcomes, and this is very important to see, is that the preliminary results, the outcomes were intended at the beginning to reduce by 20% the antimicrobial use. But then on the preliminary results, there we have that there was a 50% reduction of the diarrhea in the weaning piglets after the implementation of the colostrum protocol, which is like half of what it was expected. The use of antimicrobials was reduced from 13.6 milligrams per kilogram to 1.2, so a dramatic reduction as well. There was more weight gain in the intervention group, so 45.4%, and also their IgG levels were incremented after giving the colostrum. And then something important to say, and by this dramatic reduction of antimicrobials, is that the feed in Colombia, and this happens in a lot of sectors in LMICs, it comes medicated. So we managed for this project to have a company that was, and it was very hard to find, but a company that was happy to produce feed without antimicrobials. So this is another thing. None of these piglets have any antimicrobials in their feed or in their system. So by reducing this by only the intake of colostrum, it is great. However, some qualitative and economic analysis is still being done, but some of the preliminary of the qualitative analysis that was done to the farmers, it was that they thought it was a very nice intervention, but it takes time, it takes resources, and it's tiring. So yeah, so it's okay. Yeah, it's worth it and it reduces diarrhea, but we need to know if it's going to be something that will be cost effective as well, because at the end of the day, the farmers just want the profit. Besides among everything, it's also how much will this cost me too. So this is currently being done. We don't have any results yet. We are expecting. The team is expecting to publish results by the end of the year. So keep tuned or stay tuned for this. But yeah, what we have that is preliminary. It's very nice. And also we are having actually next week an event with FAO in which we're going to have regional cross learning opportunities and also the formal closure of this project. I promise I won't take longer. It's just 2 projects more. So the other one, it's in human health. So this one is in Colombia too. So there we're working with the Ministry of Health by developing a multimodal strategy to decrease and or limit the dissemination of CREs in public healthcare institutions. So we're working in 5 ICUs in the country. And we are implementing a mixed method study, including quality improvement methodology, so a before and after study, in-depth interviews and economic analysis to implement and evaluate an IPC multimodal strategy. So we have a development of a bundle to standard operating procedures for the prevention of CRE colonization infection, capacity building and educational strategies for healthcare workers and ICU staff, and hand hygiene PPUs, patient hygiene, contact isolation, and hospital environment disinfection. We're also doing CRE screening and monitoring and audit and feedback. So it's a very comprehensive multimodal approach we are trying to implement in Colombia. Currently, this project is just starting. So now they have done the baseline. And with the baseline assessment, they have realized that a lot of the cleaner operators, for example, they're not engaged from the beginning, so they don't even know what they're with which kind of material they're cleaning with. They just are giving the soap and that's it, but they don't know how to properly clean the facilities. And then there's a lot of disconnect between the administrative part of the hospital compared to what is being done, in their daily cleaning tasks, and also that there is not enough human resources to monitor IPC in the hospital. Nothing that is not expected, right? So there we're working, and the research partner is Universidad del Bosque, so that's our lead research institution. And as I said, the MOH. And it's very important because here the Ministry of Health has been involved from the beginning, and they have shown strong support. So a lot of the hospitals have accepted us better because the MOH has a representative that is a champion with each hospital and visits them frequently. So that's why it's important to engage these stakeholders from the beginning. So as I mentioned, this is also going to have an economic evaluation and cost-benefit analysis. Is it better to prevent infection than not? And we want to understand the KAP, so knowledge, attitudes, and practice of the cleaners, healthcare workers, and the hospitals administrators by doing in-depth interviews. And last but not least, we have another project in Georgia. Is in the phases of ending. So this one was specific for surgical antibiotic prophylaxis. So there's of course an overuse of antibiotics due to the surgical, the prophylaxis that is given in people going in surgery. So here we had different partners in country, but mainly we were working with the National Center for Disease Control and Public Health and healthcare professionals from selected hospitals. So the results are that all hospitals within this 3-year project, and I'm going to focus on this, achieved a sustainable 60% compliance with the SAP guidelines after 1 year of implementation without impacting on the incidence of surgical site infections. So we saw that even though trying to cover minimal requirements according to the WHO toolkit for surgical site infections, all of them had 60% compliance. And also as a result of this project, there's courses that have been developed, the British Society of Antibiotic Chemotherapy. So there's also digital courses that have been developed together and in Georgian. So we have had more than 600 participants and a lot of them surgeons. And something to note, and for the surgeons in this talk, if we have some, it's very hard to change the behavior of surgeons in the ORs. And for the doctors working here, they might understand that. But it was great to see that, in country, we had a workshop with them. And actually, they were happy to someone that was guiding them throughout the process of prescribing antibiotics, because they said that no one told them how to do it. And some of them were more reluctant than others, but at the end, they were happy to receive this feedback by our infectious disease doctor in the project Marika. So now something that is very important is that the national implementation and evaluation of these guidelines have included as a priority action in the new AMR National Action Plan. So the National Action Plan in Georgia has a mandatory priority action, which is to prevent surgical site infections as a result of this project. And the economic analysis from only 3 hospitals, because not all of the hospitals were able to do the full economical analysis, suggests that it's a positive cost-benefit ratio. So it's better to prevent infection than by surgical antibiotic prophylaxis programs than to treat infection. And then I just want to end with some lessons for sustainability. And I wanted to show this photo because I think it's important. And this is me working with the Port Colombia team in Colombia. I didn't know anything about pigs before. I wasn't interested in pigs. I don't even eat pig meat. So, but then when I was involved in this project, I was like, oh, it would be so interesting to understand how antimicrobials are used in the pig sector. And I'm not even a veterinarian, but I think we have to start thinking and working more with a One Health perspective. So that means try to engage more, what is happening in animal health, what is happening in plant health, because a lot of things are, actually interchanged or interlaced. So a lot of lessons can be learned in that way. And even, for training, while training our medical students, I think we should be having more of these conversations across sectors to prevent infection or to prevent future pandemics, because they will come for sure. So we have to understand local context and identify key enablers for scaling up AMS and IPC and LMICs. So it's important to understand their context, what they have in place. So adopt the One Health perspective in designing and implementing interventions, bridging policy and science to inform action, integrate AMR priorities in the broader health and development agendas. So it's not only having AMR somewhere there. Oh yeah, I think we need to include AMR because it's modern. Everyone is talking about AMR these days. We should include it somewhere. No, no, no. It should be included from the beginning as a priority. Establish sustainable funding mechanisms to support AMR mitigation. So it's not only having it in the agenda, but also providing specific budget for it. Promote the responsible and equitable use of antimicrobials, and engage governments early. And I think this is vital. We need to start talking more with policymakers, even if it's hard, so they can be engaged from the beginning. Not only that, but academia, civil society, and key partners. We should talk more with key individuals, people in the community, what they are doing, what do they think about antibiotics. It's very common, for example, in my setting that, the friend of a friend of a friend has some leftovers of antibiotics, so it's fine for them. Oh, do you have diarrhea? Just have them. So why, to understand that behavior is something that you learned, is something that is easy, that is affordable for you. Why are you doing these things? So try to engage in that way and not try to reinvent the wheel from the beginning. So I think that's it from my side. I will leave I have talked a lot already, so I will leave the door for any questions or any kind of discussion. I would be happy to hear more from you and yeah, to have some feedback from my presentation. Thank you.
Thank you, Mabel. So just before giving you the floor, Edward, well, we have several reactions in the chat. Saying that well, we are a bit lucky in Europe when it comes to regulation in animal health and also protecting the consumers. So indeed, I think it's important to mention that yes, in Europe the regulation is really strong, and which is a chance for us consumers. And that, contrary to the global scene, the trend is a bit different in Europe. So yes, Edward.
Yeah, what I wanted to bring actually picks up on what you just said, because I saw the post in the chat, and indeed antibiotic use in animal, because I'm a veterinary surgeon, by the way, and intervention in pigs is definitely very relevant. Indeed, in the animal sector, the reason why there is a reduction in antibiotics in the animal sector in Europe is because they've improved health of the animals, they improved the environment and how they farm. And that is the intervention I wanted to make, because the aspect of making people healthy, making crops healthy, making animals healthy was absent in your presentation, even though everything you do is really spot on, because you got this multidisciplinary view, and that's really important, because it is not just one thing, it's a multidisciplinary approach that is needed. So I think your intervention was really, really spot on from that point of view, but I just missed that health aspect. And you did mention a little bit, if you make your animals healthy, like in the case of your pigs, give them colostrum, that's just basic health stuff, they improve. And so I think that is really missing, because I think I've been educated, and we still are educated very much in the view that infectious disease has to do with bacteria. But we forget on the other side, it's the receptor of the bacteria. If we make them healthy and more resilient, but we have less problems with infectious disease. And that aspect is never mentioned in any national action plan. It's not even on the WHO or FIO website. It's just not mentioned. And that is really, really missing for me. And the same with One Health. You see, One Health is quite often looked at the transmission of bacteria from one to the other. And luckily, you look at it also the transmission of AMR from one system to another. That is really important. But we should also look at One Health from a transmission of health from the soil to the animals, to the crops, to the people, and the other way around. Because and these are things that I always miss in all the debates on AMR. It's just never there. And if you talk about how can we make people healthier and find other ways to look after their health, they won't need the antibiotics anymore. They won't need to rely on them. But that's all. That's what we tell them. That's all they have. You have an infectious disease. You have to get rid of the pathogen to get better. There's other ways of doing this, and I think that's what I'm missing in the alternatives. And so I've just put a few. We'll put a few links to website things in the chat. I'll put them in there now. And at the end, there's even a pig study who did the same thing, and that's always overlooked, using homeopathy, did exactly the same thing, a very high level, high quality study. So there's lots of things, and definitely the traditional sector is completely ignored in this thing, although it's doing a lot of stuff. And we're looking more at making healthy than killing bacteria. And that's a concept jump, which is going to be very difficult to make. But it's really important we start working on that as well. So that's what I wanted to contribute. Thank you.
Thank you, Edward. And if I can reply to that, sorry, to the moderator. Yeah, I agree, definitely. And that is something that we were trying to do in this project also. Like, okay, we have to strengthen vaccination, so AMR sensitive measures. So let's try to strengthen vaccination and the colostrum, because it's, like you said, something that it comes natural. However, I feel like in a lot of like low middle income countries and working more in these settings is very hard to change behavior, as I mentioned. So it's very hard to tell them, hey, if you're healthy, you don't need antibiotics, And there's people that deal with chronic diseases, that deal with, lack of water and sanitation and treatment. So it's a lot of, the prevention is not there. In some contexts, the prevention is non-existent. So I think that is why, and I'm not saying this is true for all of the projects that we have, because in most of them, we try to have the prevention in mind first, try to strengthen the health, and then based on that, reduce antimicrobial use. But in a lot of settings, the prevention is non-existent. So we work with what we have basically, and that's why I wanted to make this in the presentation very, very clear, because in some contexts we don't have that. So for example, in Colombia, and this is just a learning that we had, and it was interesting. The team came to me and they were like, you know what, we have a problem, because according to our study, we want to have the intervention done at the same time for all of our hospitals. But the problem is that one of our hospitals, the patients there, they don't want to be screened, because that means that they need to do fecal screen and colorectal and fecal screening, and they don't want to have the colorectal swab, because they feel it's against their culture and their ethics. So even sometimes, patients in ICU sometimes are sedated, so they're not even feeling anything. But when they came because they need to sign the consent, right? So when they come into their families and asking them for the consent, they were like, no, don't do this to my family member. I don't want to be like, they're doing rectal screening. No, that's not acceptable. So imagine like trying to change that behavior. It's quite hard, even because they understand it's for scientific research aspects, is to prevent infection, is to prevent the spreading of AMR, but still they are reluctant to do this, and sometimes this is overlooked. But I agree. I think we have to, in the One Health, we it's not only it's not only treating infection, right? But it's also strengthening the health of the sectors, across the sector. So yeah, I agree. And thank you for that comment.
Oh, by the way, I'll put a link to a university in India who's doing this with Ayurvedic medicine. They do a lot of really interesting work.
Oh, okay. Sounds good. Thank you. I'll check it after. Thank you.
So we have a question in the chat from Karina. So I don't know, Karina, if you want to take the floor, or otherwise I can just read your question. Well, I think I can read the question then. So the question is basically, as we mentioned, Europe has put a lot of efforts to try to advance on AMR and One Health and how to implement One Health intervention. So the question is how to support the knowledge transition from what we are doing in Europe to basically the rest of the world. So that's a bit the spirit of the question. So if you have tips.
Yes, thank you for that question, Karina. So I think it's very important to share the knowledge that we have, because sometimes it's just basic things like, I mean, and also I think it's a problem with the word antimicrobial resistance. Like even the word is so, you know, so hard. When I tell the people, oh, what do you do? I'm like, I work in antimicrobial resistance. It's like, oh, blah, blah, blah. What's that, right? It's like a tongue twister. So even that word I don't like. But I think we need to be open to have these like lay audience discussions, you know. And I think the equity aspect of it is quite hard. We also work in ICARS with a gender and equity perspective, because sometimes if you try to cover one sector and you forget about the other. So we try to also cover this, and for example, in some farms, and we have realized this in some farms in Africa, the woman is the one that leads the farm, not the man. And you may think the other way around, but it's the woman. So we want to tackle and, you know, to work with them directly. So I think I won't be able to give you a lot of tips and tricks, because you know, I'm not European. I didn't grow in a European context, so for me it will be a bit hard. But if I can come with a tip from where I come from, it's basically try to not, and I would say this, you know, as polite as I can, you know, but being honest, it's not just coming to teach another like, oh yeah, I know better, but it's just like, what do you have? Which challenge do you have at what we can share and work in a solution together? Because I know, and sometimes this comes a lot, like, yeah, because I know better. In Europe, we do this. In Europe, we have this system. In Europe, you know, but I think it's more like, okay, which system, what else you can show me, because there's a lot of things happening, like for example this study that you sent to us, Edward, like Ayurvedic medicine, you know. Oh wow, that is interesting. What you can show to me that I could also use. So I think it's an interchange of solutions and an interchange of discussions that could happen easily. And also, yeah, without forgetting the equity and gender lens, because it's not the same. You know, also we know this in the human sector, right? Like UTIs are more frequent in women, but why? You know, why is that happening? It's not in my. I remember like reading my medical books. Yeah, this is just a fact, but no one asks why. Is it that, you know? Is it at an anatomical? Is it because women are, you know, I don't know. In some countries, for example, women cannot go to the doctor alone. They need to come with their husbands. In some settings, oh no, they can only go with female doctors. So maybe they don't want to go with the male doctor that is in the village. They want to wait for the female, and then they take forever. So it's very multifactorial. And I think we have to think with that open mind and not just say, oh yeah, because we have this in place, you should follow that protocol. I think we have to think out of the box. So I don't know. I think I don't know if I replied to your question, but yeah, this would be my conclusion.
Thank you, Mabel. So time is running, but I see a lot of interest in the chat. So maybe one last question. The question from Diana, because she asked several times in the chat. So at some point in your presentation, you mentioned pool procurement for animal health. So I think Diana is asking for more information on that.
So where exactly in my presentation? Sorry.
I think it's the slide where you have the cycle with the different sectors and information on access, care, and yeah.
Yeah. Okay, I just want to go back to that slide. Maybe I can share it. Oh yeah, pool procurement in access. Yeah, yeah, yeah. So pool procurement means that like it's a mechanism where multiple entities, regions, countries, they purchase veterinary medicines, vaccines, and diagnostics together. So it's to increase efficiency. So several countries working together in procuring these medicines for the animal healthcare sector. So this is also to improve equitable access to something that we were just discussing, because in low middle income countries, the efforts are very siloed. So it's very local how the procurement is being done in the country. So for example, right now that we're going to Colombia is the first time that they do a regional meeting specifically for terrestrial animals. So before that, it was like Colombia only, and they weren't working with another country in Latin America. So now we are happy that we can start fostering those conversations and maybe talk about pool procurement in the future. But I think this will come like way in the future. But it's interesting to see, because now that I work in Copenhagen, I heard that the Nordic countries, for example, have these forums in which they talk about, okay, this is what we have in the human health sector in Sweden. What do you have in Denmark? What do you have in Norway? And then this is what we have in the animal health sector, or in the European region. This is what we do. So for me, it was very interesting to see that these conversations happen and the lessons learned are shared, which is something that doesn't happen in Latin America. And in other regions, like it's very local, very national. So pool procurement is related to that, how these efforts can come like from different countries together to ensure that the procurement continues across the supply chain.
And we have a related question from Diana. Does this procurement covers only vaccine or also antibiotics?
No, it's also for antibiotics. It's anything in the supply chain management to prevent infections. So diagnostics, antibiotics, vaccines, yeah, any kind of treatment.
Well, thank you. And yeah, I think pool procurement is a really interesting tool. And there are also several initiatives actually in Europe in human and animal health. So yeah, definitely a great tool to secure access.
And I think it's something to learn as well, of what Europe is doing in this One Health procurement, because I think these conversations should happen more. So I think it's a great learning of what Europe is doing on this, and we should show this more to the countries we work with in ICARS. Yeah.
Thank you, Mabel. And well, thank you for this really nice presentation and nice overview. Indeed, we have to remember that well, AMR is a really global issue, and that AMR do not stop at borders. So yeah, international intervention are important, and sustainable intervention especially. So I think we have a lot of in common between JAMRAI and ICARS. Yeah, so thank you for this great presentation.
Thank you all, and thank you everyone for the invitation. I'm happy to also share my slides and my email if anyone has further questions. Thank you, everyone.